Welcome to the Animal Heartbeat, still the world's only podcast dedicated to the fascinating topic of veterinary cardiology. Not only the only podcast, but the best podcast on veterinary cardiology. I'm Kieran, Borgea, and I am here with my co-host and brother in cardiology, Jose Novo Matos. Welcome, Jose, to season 2 of the Animal Heartbeat.
Hi, Kieran. Yes, very exciting. Starting season 2. That's, very promising season.
It's an unusual start to the season because we are about to hand over to ourselves at a recording of a live podcast event.
And we had this amazing opportunity to record a live podcast at the St. John's College. Really nice venue, wasn't it?
Place,
very beautiful. Some of our listeners were able to join us, which was great to have people in front of us.
Well, hopefully people can enjoy that now. And if they were there, thank you for coming. And please, we hope you enjoy listening to it again. The sound quality of the recording is not what we would like it to be, but hopefully you'll just feel like you're there and get the atmosphere of the ambience of the old Divinity Lecture Theatre at St. John's College, Cambridge. So the podcast is about human heart disease versus canine heart disease, and specifically thinking about the differences in our approach to surgery on the mitral and aortic valves. And we were very, very lucky to be joined by a fantastic panel of experts from the human and veterinary cardiology worlds.
Exactly. Amazing opportunity to listen to top specialists, vet cardiologists and human surgeons on this very exciting topic.
Sit tight for the next 90 minutes of expert cardiology discussion.
Welcome, everyone. Thank you very much for joining us today. We are very excited to have our very first live podcast.
He's so excited, I say terrified, but fantastic. Normally we can just edit things out. So if we backtrack, we're just falling into a pattern of behaviour from doing this on Zoom. It's the first time we've ever actually met, isn't
That's
it?
True. And so we are very excited really today to be talking to you about heart surgery in dogs and humans. We have a fantastic panel. Thank you very much indeed for accepting our invitation. It's a huge honor for us. So we have two human, they're all humans, but we have two human one human cardiologist, one human cardiothoracic surgeon, and then two veterinary cardiologists with a large experience in heart surgery in dogs.
Really nice to see you all here. I'm Ravi de Silva, I'm a cardiac surgeon. I work at Royal Papworth, previously worked at the John Radcliffe in Oxford as a consultant. I've been in and around East Anglia for the majority of my career, having trained at Papworth before that. And my specialty is adult cardiac surgery, but particularly focusing on aortic surgery and surgery, a particular type of surgery for coronary artery disease and minimally invasive surgery. Nice to meet you all.
Thank you. Do I introduce myself?
Go for it.
Hi, I'm Anne. I work at White Referrals, and I've been involved with heart surgery probably from when I was a resident at the RVC. Prior to that, I did a 1-year stint in Japan, training under pretty much, the pioneer of mitral valve repair, Dr. Masami Uechi. And Puppy and I have been operating at GWR since 2021. Unfortunately, our program is currently halted, but I'm sure Puppy is going to have ample opportunities to continue performing the surgery, so please watch this space for her. Thank you.
Hi everyone, my name is Rohin Francis. I'm a human cardiologist based at the Essex Cardiothoracic Centre in Basildon. I started my training in Papworth. I went down market to Essex. And,
that's a matter of perspective.
No, it's pretty true. I'm a coronary interventionist as my sort of subspecialty, but I'm a general cardiologist at Colchester District General. I know we're focusing on valves a bit more today, so that my more general part of my role is in Colchester DGH. Yep, nice to be here.
I'm Claudio Bussadori from Milan, Italy. I spent my experience and my training the last 40 years initially with veterinary cardiology. I graduated as a veterinarian, then I got the European College diploma. Honestly, I'm one of the oldest guy in the group because I've been one of the founder. And then I moved on the human medicine, and I got my degree and got my specialty in cardiology. But all my time, all my interest have been spent on congenital heart disease mostly. So I've been practicing interventional cardiology either in human and human child and human adult and in dogs. So I export my experience in the veterinary field, so doing some interventional procedures, what are now the most common one. When I started 30 years ago, were not so common. And now even the newest one, we are trying to practice, and then we started together doing this practice. So I would say, as a global cardiologist, I'm mostly interested on the congenital disease, to understand the genetic, to understand the treatment, to understand the pathophysiology. So, and I want to thank you to invite me. That's a beautiful environment, and to have this beautiful experience. I'm sure I will learn something.
I think Claudio is here on holiday, and everybody else is local. So thanks for Claudio for joining us from overseas. Fantastic. Do you want to introduce yourself? I'm going to introduce you.
Okay.
This is Professor Jose Novo Matos, who is one of the founding members of the cardiology community to use the acronym FIMS, standing for Thin Hypokinetic Myocardial Segments. It's changed how we work. Honestly, I love abbreviations, and it's really brought an additional one into my life. Thank you.
Yeah. So Kieran is a vet cardiologist and amateur podcaster. He's a father of 5 kids, 1 dog and 1 cat. Funny fact about him, I just Googled it today. So he has this funny surname, Borgea. So Borgea originated from a small village in the French-speaking Switzerland called Champery, where there's a shop called the Borgea Sports, which are specialized in renting snowboards and skis since 1959. Correct.
I've never skied.
That's a fact.
They went down market with me, I think, moving to Colchester. We're going to begin the discussion by talking about mitral valve surgery. This is obviously a hot topic in dogs, but far more extensively understood in humans and extensively performed in humans. So Ravi, tell us a little bit about the surgical techniques that are available for managing mitral regurgitation in humans, and if you can, just a little bit about why those surgeries are performed. So what's the spectrum of disease that we see in people that undergo mitral surgery?
Thanks, Kieran. So the commonest reason in the Western world for people undergoing mitral surgery is degenerative disease, but throughout the rest of the planet, probably still the commonest reason is rheumatic heart disease. And so if we look at our practice here, it's primarily degenerative. It's people who have mitral valve regurgitation, although we do see a fair proportion of people with degenerative disease with stenotic mitral valve problems. And in terms of the treatment, well, the treatment has changed immensely in the course of cardiac surgery. Cardiac surgery is a very recent subspecialty of surgery. We've only been around since the advent of the cardiopulmonary bypass machine, which is in the mid-50s. So initially, the idea was, got a problem with the valve, chop it out and give them a new one. And people eventually realized that perhaps, particularly in the case of the mitral valve, that there's more to this parachute-like valve than meets the eye, and in fact those attachments of the valve are really important. So the emphasis then moved towards preservation. So that's really where we're still at now. More and more techniques of preserving the valve and repairing the valve back to a state where its integrity is restored. The advances recently are around how we actually do that, and by that I mean how we approach the heart, whether it's through the old-fashioned stenotomy, cut down the center of your chest, whether it's more recent advances in minimally invasive surgery, be that robotic or just through a thoracotomy, So really, those are the surgical techniques. I'm sure Rohin will talk more about the cardiology techniques, so I won't steal his thunder. But certainly, that's the way mitral valve surgery has evolved in adult human work.
What is the right stage to intervene? There's a big debate in veterinary cardiology. How do we define the right time to send our patients for surgery? How do you define at what stage of mitral regurgitation the degenerative mitral valve disease is indicated to perform heart surgery?
Once again, I think there's an evolution in our treatment paradigms, and Rohin is, I think, still best placed to talk about it, because as a cardiac surgeon, we see patients as a service provider. And that's to say there's a cardiologist who's generally worked the patient up, and once they've met criteria for surgery, we see them in a clinic and get on and operate on them. So, in many ways, I think Rohin is probably best placed to talk about that. But the bottom line is we do surgery for two reasons, and that applies to any form of surgery. You do surgery to improve someone's symptoms and or to make them feel, to make them live longer. Okay, so symptoms or prognosis. And if you can tick one, preferably both of those boxes, then that's the time to operate. And ideally, you operate before there's been irreversible damage and there's every chance of regaining full cardiac function.
Amazing.
Somebody once told me a long time ago that the left ventricle and the mitral valve should be considered as kind of one entity. So a problem with the mitral valve leads to a problem with the left ventricle and vice versa. And once you consider them as a single kind of entity, then you start to understand sort of the indications for surgery a bit better. As Ravi's already said, there are really only two indications to intervene, which is symptoms or prognostic benefit. And mitral valve disease can be broadly split into primary or secondary, if you're talking about mitral regurgitation disease. So primary mitral regurgitation is a problem with the valve, so mitral valve prolapse, Barlow's valve, some kind of anatomical issue, cord rupture, something like that. And in that case, you've got a clear indication. For degenerative and for secondary valve disease, so functional mitral regurgitation, where you've got a dilated left ventricle, heart failure, and poor coaptation of the mitral valve, we don't have any prognostic data to show that intervening in the absence of symptoms is going to do any benefit. So in that case, it is symptoms that are guiding you. And the majority of patients who have a primary problem will get intervention, whereas secondary mitral regurgitation actually, probably it's the minority that go forward for surgery. In terms of the deciding factors, then you are looking at your left ventricle really as the main. There are echo criteria, and I think one of the questions you mentioning that we might talk about is kind of which imaging modality,
right.
And it's very much echocardiography for all valvular disease. It's still very much the mainstay, but for the mitral valve you might get a transesophageal echo in addition to a transthoracic echo, and there are multiple echo criteria, but we've probably in the last few years with updates of guidelines moved towards a slightly more intervening a little bit earlier in the disease process. There's more understanding that a lot of these LV changes, once they've occurred, are not going to remodel. So we probably intervene a little earlier than before.
It's reassuring, I think, for us to hear you talk about echo being the best way to assess these patients, because I think most vets think, well, in humans, they've got MRI, and we've got MRI scanners, but to be MRI, our patients are anaesthetised. And, therefore, everything changes. It's much more challenging to assess. It's very hard to get any dynamic images with MRI. So, of course, we're completely reliant on the echo to really accurately assess the heart.
Well, you mentioned primary and secondary mitral regurgitation, and even though we are talking about primary mitral valve disease with degenerative disease, we tend to operate these dogs much later than you would operate a human. So we have a lot of then functional MR due to severe mitral venous dilation and so on. And could you comment on that? How much would that impact the success of mitral valve repair? Because my understanding is in humans maybe just mitral valve repair in some cases would be enough, and potentially without amyloplasty. But I would like to hear Ravi's opinion about it. In your case, of course, you operate dogs that have severe left ventricular remodeling and eccentric hypertrophy, and so they will have severe dilated annulus, which will also cause the secondary regurg.
I was just at a conference in Colorado discussing this about TEER versus mitral valve repair and annular dilation. And for us, I think systolic function, as much as we can assess on echo, is probably the most important in terms of candidates that we may not operate on. Mainly because, after we do a repair, I fortunately work with a surgeon that does a really good repair, and you may have no MR post-op. And then the systolic function may be affected secondary to that, or the degree of systolic dysfunction prior to surgery might be unmasked. And the heart might not shrink, and they might go into heart failure within a year or something like that, which is obviously unfortunate. But I think compared to humans, I think we are a little bit more lenient, mainly because we're not expecting our dogs to live 20 years, 10 years after mitral valve repair. I think Dr. Ritchie's median survival time in terms of dogs that, because they're geriatric dogs that get this operation, we're averaging 5 years post-op, and they might get cancer or other diseases, and unfortunately they might pass away from that. So our goal is not 20 years, like in humans, so we accept a degree of systolic dysfunction, and we operate on dogs with disease that is quite advanced compared to the human side.
What bit of your question do you want me to answer?
I thought as you operate at the earlier stage of the disease and we operate much later, in our case there is severe left ventricular remodeling.
Yeah.
And these patients who have initially primary mitral regurg, and then mitral regurg begets mitral regurg, and their annulus dilates and everything gets worse. And so my understanding from the veterinary field is surgeons will need, annuloplasty is a really important component of the mitral valve repair. What I was interested in is in the operations, in the patients you operate, how much annulus dilation there is, how much functional MR there is at that stage, and how important is annuloplasty in your patients.
Sure, so it's unlikely that in the case of mitral regurg, it's really unlikely we'd be operating unless the regurgitation was significant. Okay, or there was evidence that the left ventricle was starting to fail, and or the patient is symptomatic. That being said, one other thing we didn't mention was about exercise echoes and assessing that, and I don't know whether that happens in the animal world or not, but I think it's a really good way of differentiating younger patients or fitter patients who have a pathology but are not symptomatic. So you don't really know whether it's right to operate, but you put them on a pedal bike and then echo them, and you realize that their mitral dysfunction is actually significant at peak exercise. So that's one thing. The other thing is I don't think, still, despite all our technology, we still don't get it right a lot of the time, and our understanding of the left ventricle and its involvement with the mitral valve is still not perfect. I'll explain that in that if you have cardiac surgery in general in the UK, your chances of dying are between 1 and 2%. For mitral valve surgery, that's up to about 3%. For mitral valve surgery combined with coronary artery bypass grafting, that's up to about 8 to 10%. So clearly there's a lot about the mitral valve, its involvement of the left ventricle, and the synergy between mitral valve disease and ischemic heart disease that we still don't fully appreciate. And perhaps we need to change our treatment paradigm to bring these patients towards surgery at an earlier stage.
How do you assess severity of mitral regurg in dogs? What is the gold standard variables on echo to assess mitral regurg in dogs?
Yeah. Just to catch the translational aspect of what we are discussing, we have to consider that there is so much difference in the speed of the evolution, because of course, especially in cavalry charts, they develop mitral valve disease, even severe, with the severe degeneration, severe hemodynamic at 6-7 years of age. And then some of these bloodline, they do not reach the age of 10 years generally. The other one, with medical treatment, they can survive. So other things, sorry if I make even this comment, but I think it's important. Talking about the ventricular function, that's a different evolution, because in dogs you have so evidence of hyperkinetic function due to the volume overload that develops so fast. That's something we don't see in human. In human we see the primary mitral regurgitation with the barrel syndrome, so with kind of prolapse and maybe this primary regurgitation, but this hyperkinetic ventricle we see in dogs we don't see. And we don't see this developing of large ventricle. And so this is the reason why we have difficulty to understand the systolic function, because in human also, when you talk about secondary mitral regurgitation, sometimes related even to coronary disease, they have, so the patient who undergo to mitral tube, most of them, they have just a primary left ventricular dilatation and then they have lack of contact. So comparing these two different aspects, I think we have to take care that there is a different natural history. Anyway, this is the major concern. How to evaluate in a dog with a severe mitral regurgitation the systolic function. Quite difficult because, of course, there is Starling mechanism that give you this impression. And also to evaluate the systolic function after the surgery or after transcatheter V-clamp, what we use. And so what we see after, now I'm watching the patient after 2-3 years, so there is no remodeling at all because we intervene at the advanced age, about 10-12 years. It's not like closing a PDA, then they return to a normal heart. They remain large, but of course, if they don't have mitral regurgitation anymore, or with the transcatheter system, they still have some regurgitation, but you know, with your surgery, perhaps they don't have it anymore. Of course, their ejection fraction is low, but I don't want to I don't esteem the systolic function by that ejection fraction, but by the cardiac output. The cardiac output is going in the right direction. For this reason, they do not change the shape of the heart. So I would not say this patient has a systolic dysfunction. This patient has a large, oversized heart. They remain oversized. Then after, the second problem is to auto-evaluate the mitral regurgitation. You know, I'm used to say that if we have so many echocardiographic index to evaluate mitral regurgitation, to quantify it, that means there is no one good, because we have too many. And so, for example, I tried to apply PISA in animals, and you know, I think, in my opinion, PISA works only in secondary mitral regurgitation in human. And then once we discovered the 3D echocardiography, and once we discovered the X-plane, and so if you go the X-plane of the PISA, then you measure the size of the other. Then you go on the perpendicular view, and you see a completely different PISA.
Yeah.
And in a dog that you have a mitral degeneration with so many changes of the structure, to use some nice system like PISA, it's fascinating. I think probably doesn't work. So in my experience, what I do a volumetric quantification. Of course, since I'm not sure about the mitral area, what I do to calculate the systemic, the total cardiac output, I use the difference between systolic and diastolic volume, and that's it. And then I measure the other one, and then I get the quantity, the regurgitant fraction. That's probably the more reliable thing. But you know, to select patient, for example, to use the transapical approach, so it's a sort of mitral clip that you put transapically, of course, because of the dimension of the dog. I think we are learning step by step. Step by step, we are learning because we're watching the results. So we are still in the process of understanding which patient can benefit. We have patients with a fantastic improvement. We have patients that didn't get an improvement. There are so many indicators.
Are there patients we wouldn't intervene on? who would we not touch because we think the outcome is likely to be poor or worse with some sort of surgical intervention? So first to think about humans with mitral regurgitation. Are there patients that you just say, they're not suitable, sorry?
Yeah, sure. I mean, of course, the majority of our patients are pretty elderly, and so there are multiple different risk scoring criteria. But a lot of the time, it's something that you don't necessarily always need formal risk stratification. But obviously, I'm sure a lot of the medical problems that are pretty self-evident, things like COPD being a major one. So routine workup for cardiac surgery would involve lung function studies, and that disqualifies probably the biggest group. And then any sort of other markers of frailty. In terms of the technical side, I'll probably leave Ravi to answer, but in terms of the interventional kind of therapies, which are, it sounds like perhaps there's more experience in the veterinary world when it comes to TEER, because certainly in the UK it's still quite a new procedure, which is the trans-catheter edge-to-edge repair of the mitral valve, and really I think only Oxford does it for the tricuspid. And we've just started it in the last year or so in Essex, and there you have to have quite specific requirements in terms of the valve itself to have a good result from a clip. Mitral Clip's a brand that we don't use, so I'm not allowed to say that. We use the Pascal device. But yes, in terms of, I think, just to respond to one thing Claudio was saying, that about not a specific number or a specific parameter. So there are two kind of deliberate movements in the most recent American and European guidelines. One was moving away from specific numbers, like magic numbers, to take a more holistic approach, because you might, be misled by a specific parameter and sort of fixate on that. So now we try and look for multiple different measurements of severity and LV dysfunction. And the other one was moving towards a real MDT approach, which is the multidisciplinary team, where now really we should be, all of these patients should be going through a team which has a surgeon, a cardiologist, an imaging cardiologist, as well as an interventional one, perhaps a geriatrician a lot of the time, specialist nurses, to address exactly that whether we are choosing patients who are going to have a good outcome. There are different scoring systems, but I think each hospital will maybe have different preferences, but that's absolutely a key thing. Sure. And a lot of the time it is telling patients that it's prohibitively risky to go ahead.
And how are those patients managed, if not surgically? What are the alternatives for humans with mitral regurgitation?
It's pretty unsophisticated stuff, really. Dilators, ACE inhibitors, and heart failure treatment. Mitral regurgitation, as opposed to mitral stenosis, tend to have a very large venous reservoir, so they do tend to respond well to diuretics, and so often you'll manage with that. But ultimately, for these surgical problems, there's no real effective medication, so it's just going to be supportive management.
Okay. And Ravi, anything to add in terms of technical exclusion factors?
No, I think, Rohin's covered a lot of it, but, heart surgery is really tough on patients. And in the post-operative period, it's hard on their lungs, it's hard on their kidneys. We demand a lot of them in terms of mobilisation, because the patients who don't mobilise after heart surgery end up dying in hospital, generally from those fungal infections. So,
get back on the echo bag.
Yeah, exactly. So, a lot of it depends on the patient as they walk into your clinic room. They don't always have to walk in. Some can be in a wheelchair, but they may still be suitable for surgery because there's no other options, and you think that this is possibly going to help. And age is not the defining factor. Patients in their 70s who are clearly too decrepit to withstand cardiac surgery, and those in their 80s. The oldest I've operated on is 96, but so it doesn't really, age in itself is not an indicator of fitness for surgery.
Interesting.
Can you just tell us, we have been talking a lot about mitral valve repair, and that's the technique we use and what we use in dogs. When is mitral valve replacement indicated? In which case do you perform mitral valve replacement?
So bottom line is you go into every mitral valve repair operation, and that replacement's your bailout. And in surgeons, I'm not a mitral specialist, I'm an aortic specialist, but my mitral colleagues, they will push the envelope far further than I will in theatre and achieve a repair where I wouldn't be able to. And so really for them, their point at which they bail out and replace is different to mine. Yeah, the ultimate aim is to preserve as much as possible.
And in terms of your patient population, are there patients who you would say, hard no, not a candidate?
I would say if they're in active right heart failure or not responsive to sildenafil in regards to their severe pulmonary hypertension, those are some two kind of related comorbidities that we may say no to, but certainly other, if they have cancer or any other comorbidity, those things have to be considered before putting a patient through surgery. Also, any diseases that may make the patient hypercoagulable. We have operated on dogs with well-controlled Cushing's and things like that, but those are some things that we have to just consider and make sure everything is under control, because we don't want to see any post-operative complications associated with it. So, yeah.
Regarding pulmonary hypertension, do we know where the line is? So when you perform mitral valve repair, you have profound reverse remodeling after mitral valve repair. So some of that post-capillary pulmonary hypertension will hopefully resolve.
Yeah.
How do you decide that? Do you have a magic number to say above this certain degree of pulmonary hypertension do not operate? Or in your experience, how much of some degree of post-capillary pulmonary hypertension will revert after mitral valve repair?
Well, I think the first thing we have to consider is how we're diagnosing pulmonary hypertension. So if we're just basing it on TR, tricuspid regurg, are we measuring the chin or the beard? I think those are lots of things that we have to consider. And some people, we all practice differently. So some people might be quick to start sildenafil versus, other cardiologists might wait a little bit longer. So I think those are all things that make it really complicated to determine severity of the cutoff, essentially. So I would say if they're still collapsing on high doses of sildenafil, their right heart is massive, then those are cases that we probably shouldn't operate on. And a lot of it is about educating the owners and expectations, because a lot of them, post-operatively, the pulmonary hypertension will improve, because I think a large degree of it is post-capillary. But some of them, post-operatively, they might have acute lung injury, secondary to being on the bypass machine, and they might have issues associated with that long term. So we can't really guarantee what's going to happen. So we just try to minimize, variables that may result in a less than successful outcome.
And can you just quickly comment, just to make it clear to the audience and to our human colleagues and friends, medical treatment is still the standard of care in mitral valve disease in dogs. We treat them in the preclinical stage, interestingly with a positive inotrope, because there's a randomized clinical trial that showed that this extends the subclinical stage, and then once they develop congestive heart failure, we'll treat with the standard heart failure treatment. But I'm very interested always is, after cardiac surgery, how quickly do you see reversible remodeling? How fast do you stop diuretics and positive inotropes? Yeah,
so we stop diuretics as soon as we do the surgery. There's such significant reduction in MR. They don't need furosemide post-op. We do keep them on pimobendan. I think in the early days we would, once the heart remodeled, which in some of these cases it might be whilst they're hospitalized, we did consider stopping the pimobendan, which is the inotrope, but for right now we actually do continue it at least the 1 month, most of them to the 3 months, because they are on blood thinners until 3 months post-operatively. So we just kind of use that marker, that echo, to determine whether we're going to stop the pimobendan, but most of them are off diuretics.
How quickly do you see reverse remodeling post-surgery?
Yeah, I mean pretty fast. Yeah, you'll see it within the first few weeks, and generally the surgeons will do a sort of 6-week check afterwards, and then they hand the patient back, and by that stage, you know, they're often well on the way to recovery and doing really well. So that's when we tend to pick them back up, and a lot of the time, you know, that you won't necessarily have a complete resolution of completely normal LV, so you'll stay on prognostic heart failure type beta blockers, ACE inhibitors, but certainly diuretics can be stopped pretty quickly.
So beta blockers brings us on to some interesting stuff. Differences, I think, between dogs. You're up. We're talking about beta blockers.
What's about beta blockers?
So, is there a place for using beta blockers in dogs with mitral valve disease? Pre-surgery, post-surgery?
I always say that I would put in the drinking water for everybody, beta blockers, except for asthmatic people or hyperthyroid. But you know, it seems, you know, it's a different behavior of the left ventricle in human and dogs against mitral regurgitation. So I already told you, it's so fast, the evolution, it's so severe, the degeneration. You see the same degeneration in just 1 or 2 years that you can see in a human in 10 years. So in the human makes sense because there is many times concurrent coronary disease, and they need beta blockers. I take beta blockers, of course, because I have beta blockers. The my hypertension works, and you know, I think it's a good drug and one of the main drugs on cardiology. But I don't see the reason to use in mitral regurgitant dogs, mitral regurgitation dogs. That's completely different. So it's so fast. And then even the behavior, we were talking about remodeling. So the remodeling is dogs after the surgery is just much more or less evident because it's a different condition. And also, you say the one good thing. So most of the dogs we have with mitral regurgitation, they don't need surgery. They don't need a V-clamp because they have life expectancy. If they start to develop mitral regurgitation at the age of 11, 12 years or 10 years, with a good medical treatment, they can live all their life expectancy with an acceptable quality of life. So the goal, so the ideal patient, at least in my experience, all the dogs we put to the V-clamp were cardiac Charles, 6, 7 years old, with a regurgitant fraction of 80%. They already went to pulmonary edema at the age of 6 years. That makes sense, because now we're watching this dog, they have the same size of the ventricle, with a 20-30% of regurgitant fraction, that's fine. But you know, the majority of dogs, and then we need to be honest in this way, because it's so easy to repair the mitral valve that it's a very good one, you know? It's and then you can get a good result, because of course, probably they don't need. But most of our patients don't need that. You know, and again, the problem, at least in dogs we can do that, because we cannot do in human, is the genetic control. So what we need to help a breeder to select animals that do not have this kind of disease, or at least they have a disease that develop later in life that can live together with the disease. I don't want to do intervention to everybody.
So I remembered, about 20 minutes ago, I said I had 2 questions.
Yeah.
I remembered the second question.
You asked the question.
I asked the one question. I think I had 2 questions. I had a follow-up.
Okay.
This is number 2. So the second question was coming back to minimally invasive options. And we sort of touched upon, you talked about tear a little bit in dogs. We've mentioned about the transcatheter options in humans. I think it is very new in dogs. I don't think we have a great, an extensive experience of it. My question was, when do we prioritise interventional treatment over open heart surgery for the mitral valve?
For the mitral valve, it's easy. It's currently only patients who are deemed unsuitable for surgery.
Right.
So that's straightforward enough. For the aortic valve, which I'm sure we'll come on to, that's when the indications are expanding and there's ongoing big trials with patients who could qualify for both. I mean, the backstory to this is the aforementioned mitral clip. When that first rolled out, then it actually got withdrawn and paused for a while because I think we were getting maybe a little too gung ho. So this has now come back in as TEER in a much more measured way, and I think it is very much patients who are not going to be able to have cardiac surgery.
Right.
Robbie, before we move to aortic valve disease, complete outlier, but as you are a specialist in percutaneous coronary intervention, something that I always thought very cool is not the right term because it's a very serious condition, but patients with myocardial infarcts that then develop acute papillary muscle ruptures and severe MR. If I understand it right, I think it's interesting is that may happen a few days after the myocardial infarct. What I would like to ask you is, how do you recognize these patients? Is it just because of the location of the infarct? How do you already suspect that certain patients with a myocardial infarct, inferior infarct, may develop a papillary muscle rupture? And then how do you approach, how do surgeons approach a patient with acute papillary muscle rupture?
It is typically inferior myocardial infarction because of the single blood supply. And so classically, when you think about mechanical complications after, this is typically S elevation MI, so an old money transmural infarction. You don't see it that much these days because of primary percutaneous intervention, so you don't have these kind of massive infarcts that kind of sit around. But actually in COVID we saw it return because a lot of patients were sitting at home trying to avoid going to hospital. So we saw a lot of these late complications, mechanical complications, and the dreaded ones are VSD, papillary muscle rupture, or free wall rupture, which is usually quite rapidly fatal.
Sounds serious.
Yeah, I mean, these are the patients that they come in sort of at 12 hours post onset of pain. You put a stent in, the flow is not very good at the end of the case, and then 2 days later they just arrest them all, and there's nothing you can do.
Right.
And for how do you recognise it? So it's in your inferior patients who generally are much less sick than anterior MIs. So they're quite stable on the ward. Maybe day 2, they've maybe had a late presentation, and they suddenly go into pulmonary edema. Whereas with an anterior, they've probably been overloaded, they've had an impaired LV. So these are the ones that you think are fine. Oh, they're going to get ready for home, got the discharge letter ready, and then suddenly something goes wrong. So that's your classic kind of mechanical complication. Late presentation, inferior, well, and then suddenly deteriorates.
Any chance of repair, or is this a replacement case?
I think repair would be really advisable. The very fact that they've developed acute ischemic mitral regurg, and by the way, at risk of getting shot down in a room full of veterinarians, you can recognise these patients easily because they're sick as a dog. They truly, they look really, really bad. And so the classic teaching, and I still stick by this, is just get in and restore valvular competence as soon as possible and do it with the shortest period of ischemia. In a cardiac operation, obviously you've got to stop the heart and do the operation. That implies that you're going to make it ischemic for a period, although you protect them with cardioplegic solution. But that ischemic insult is not to be underestimated, and especially in a heart with ischemic heart disease that's now got a valvular problem, an acute valvular problem. Chronic valvular problems can be tolerated for years. Acute ones are not tolerated very well at all. And so these patients, you just want to get in and out as quick as possible, and my practice is just replace the valve.
Just briefly mention cardiopulmonary bypass, and that's was something we have not talked about. And would you mind to maybe highlight what the main difference are between humans and dogs? What is challenging in cardiopulmonary bypass in dogs?
The principle is the same. You're taking blood out of the patient, you're putting oxygen in it, and you're bringing it back up. So you have a pump. So you're actually a heart and a lung machine. But I think working with lots of human perfusionists, both pediatric and adult. I think for me, I had a very interesting training with cardiopulmonary bypass in that I've never had official kind of training in a human setting. I've only had training in a veterinary setting, so I'm not 100% sure, and I think Laurent would be more knowledgeable on that side of things. But I would say the veterinary side is very basic. We don't add a lot of medications. Our setup, our circuit is very simple. We don't have a bubble trap. We don't do a lot of things that human perfusionists feel really uncomfortable about. And our circuit is very, very simple. So I think one of the perfusionists that I worked with or trained me, he would go to third world countries in a tent where they would do open heart surgery, and he'd be doing the bypass, and he's like, the setup is similar to what we do. So it's a little bit simpler, but it still works. So stand by it.
Just briefly, but does size matter? Is it more challenging to do it in a 3 kilo Chihuahua versus a 15 kilo Cavalier?
So it's what you're used to. So when we have adult perfusionists come in, they're just like, all of your tubings are so tiny that they feel uncomfortable when we're doing like a 3 kilo dog. But that's my comfort area, so I feel really comfortable with the small sets. I don't feel comfortable, I actually never done like 100 kilo dog. I think our maximum is like Labrador size, so 35, 30, somewhere around there. So I wouldn't feel comfortable if it gets bigger than that. But I mean, it's just tubing size. Your clamps, when you're clamping the tube, it's like a lot more work versus our tiny 1/4 inch tubing. So yeah, that's my comfort zone. But I think it's whatever you're trained and comfortable doing.
Yeah, thank you.
I think when I first remember hearing about cardiopulmonary bypass in dogs, people used to say, dogs don't tolerate it well. Dogs don't tolerate bypass. Humans, they're fine. I feel like we're in a different place to that now. I feel like we've learned how to do it in dogs. Am I right in thinking that? Am I missing something?
Yeah, I think we learned that simple is best in dogs, and I think a lot of times it wasn't successful because there was so much intervention involved. One of the things that Poppy and I have changed with our bypass system is that we don't actually add any blood products anymore, and we've had much better success rates in terms of post-operative outcomes and things like that. And so, just keeping things as simple as possible, don't add anything that you don't really need, and don't intervene unless it's absolutely necessary is what I've learned from doing this. Making sure the circuit is as small as possible, minimizing dilution, because you're diluting the blood with all the prime and things like that. So I think we've come a long way, learned a lot from the Japan team, and I remember when Dr. Ritchie and I operated in the US, and there's some perfusionists there in the human side, and they called us crazy for how we did the perfusion. But that's how it works in the dogs, and he's been really successful at that, and we just do exactly what he does. So yeah.
It's hard to argue with the survival rates that the Jasmine Clinic are seeing now.
Yeah.
I mean, in the high 90% survival rates, and it's tough to get that in dogs, I think.
Yeah, I think the more open you are to learning from people like that. I mean, when Puppy and I went there, end of last year, we made some changes to our program, and we've seen quite a big change in our success rates, and we are in the 90s now, which is really good. But it's hard work. You just keep learning. Every day is a school day.
Yeah.
Brilliant. Claudio, the most common aortic stenosis in dogs is subaortic stenosis versus valvular aortic stenosis in humans. Claudio, can you describe a bit what do we know about interventional surgical treatment in subaortic stenosis in dogs? Is there something that can be done, or is our case that we only manage medically?
In dogs, we had several breeds with so frequently we find subaortic stenosis. So you have to consider that in dogs, we don't have the acquired aortic stenosis. We have seen someone after some endocarditis, what else. So the aortic stenosis you see in aged people is such a common disease, very common, like mitral valve regurgitation in dogs. As the population can get older and older, and you have a lot of people that develop this calcification of the valve, what else. We don't have this in dogs. In dogs we have congenital subaortic stenosis with various patterns, so various phenotype. So the classification done 50 years ago by Patterson is still valid, but you have some various presentation, various phenotype, depending on the breed. And sometimes you have probably, I guess, around 10% of the population of dogs with aortic stenosis, they may have some valvular aortic stenosis, tricuspid or bicuspid. I observed some quadricuspid, but quadricuspid, they mostly develop insufficiency, aortic insufficiency. And I remember only one severe aortic insufficiency due to quadricuspid was a Doberman with a huge annulus, huge aortic annulus. So mostly we have subaortic stenosis with development of the progression of the disease, which is like in humans. It was a nice publication in Cardiology in the Young in perhaps more than 20 years ago. And the author, the Canadian author, describing the subaortic stenosis in children, they put even a picture of a Newfoundland dog. They're mentioning that in Newfoundland this disease was common. And you know the ratio of worsening of the disease, because the disease starts with some subaortic obstruction when they are puppies, and they develop a progression. The progression you see in dogs is mostly we see in golden retriever because they have a quite narrow septal aortic angle, more lower than 140 degrees. For this reason, there is a shear stress. I like to say shear stress because I don't know how to translate in Italian, shear stress. But you have this shear stress. There is no translation for Italian. Anyway, you have the shear stress and they develop a progression. So sometimes you see some fibrotic spore. So, what's about the attempt to do intervention? You know, I've been proposed more than 20 years ago already, but there is still no data. So there's this kind of intervention using cutting balloon and then high pressure balloon. I think there is no data about success about that, because you know, even it's quite dangerous to use a cutting balloon. And also, cutting balloon available is no more than 8 millimeters. Cutting balloon is born for something else. Of course, in this puppy, they use it to go through the carotid artery, but you can go, if you use just a guiding catheter, you can go even through the femoral artery. But you know, the point is, the puppy you see, generally they have an annulus which is more than 8 millimeters. So you can inflate your cutting balloon, but you don't cut anything. And then after cutting, they put a high pressure balloon. So the data is in the first 24 hours, it's fine. You can see some reduction, but of course, you give a shock to the left ventricle, and the left ventricle is weak in the first 24 hours. So for this reason, the gradient is decreasing.
So we're underestimating it on the echo rather than seeing a result. If you like.
Yeah, you have to estimate by echo, you have to measure the area to see if there is some change. Successful is sometimes the aortic stenosis when it's aortic stenosis, pure fusion of the leaflet. And that happens, at least at my experience, if those are tricuspid, it works well. If it's bicuspid, it's like in humans. If it's bicuspid, it doesn't work so well. Bicuspid still remain some stenosis. But that makes sense, in my opinion, to dilate with a balloon a congenital aortic stenosis. But a subaortic stenosis, the only way, once again, is the prevention. So, you know, I started in '94 in Italy to select, to help, to start with a breed screening in boxer dog. So we started with the boxer dogs. Boxer population in the south of Europe are completely different than the UK boxer. The UK boxers genetically are more related to the American boxers. So for this reason, you see several cases of cardiogenic, arrhythmogenic cardiomyopathy in boxer here in UK. In the rest of Europe, you don't see, and in US you see. Anyway, we started to select the dogs we did together with the breeder, just eliminated the dog who had the phenotype of the aortic stenosis. In '94, we had, in the first epidemiological study, we had more than 20% of the dogs affected by aortic stenosis. 20% means in a litter, maybe 1 or 2. So it was a disaster. Because the general practitioner will say, okay, it's a boxer has a murmur, that's normal. The boxer has murmur. So now we don't see anymore this disease in boxers. And now we see in Golden Retriever, we see in Doge de Bordeaux, we see in German Shepherd, general with severe phenotype, that probably there is some different genetic expression. Because in someone you see only the tunnel, someone you see only fibrous ring, someone you see only a spore and a narrow angle. In other case, you see some invasion of thick endocardium or told the left ventricle that looks like a fibrolastosis. And they develop also some diastolic dysfunction other than the systolic. What you know about the intervention, don't tell me.
I think selective breeding in humans is frowned upon. It's a treatment for heart disease. Yeah. I think it might be the solution for us long term. If we can get people on board, dog breeders on board with that. That's a huge challenge, I think. In humans, tell us about aortic stenosis, subaortic valve, in humans, and how that differs from the picture that Claudio's painting in dogs.
Well, the majority of the patients I see are going to be adult. They're going to be in their 60s, 70s, 80s. In my practice, predominantly bicuspid aortic valve are the patients that are going to see in the younger age spectrum, and the typical trileaflet degenerative valve disease are the ones that we see in the older patients. Subaortic membranes are rare, and usually they're in patients in their 30s that we see who perhaps have some sort of congenital background.
In their 30s?
30s,
wow.
Yeah. And the techniques for that are, it may involve replacement of the valve, but most of the time what you need to do is increase the annulus, and that means a different set of techniques to which you would normally employ. The results of them are variable. Some patients do really well, never come back. Some patients develop this horrible pannus, which just causes an insidious return of their symptoms. So, it's a different subset to we talk about.
Calcification is a big thing, right, in bicuspid aortic valves and so on. Does it play a role on deciding on the surgical plan how much calcification there is, and how can you quantify that calcification?
Yes, it can play a role in determining sort of what treatment to go ahead. And in fact, it may be, so a lot of the decisions now will go through, as I said, an MDT, so you'll have an aortic team, and we'll try and decide who may do better with a TAVI versus a surgical aortic valve replacement. And certainly calcium plays a big part in that decision. And I think it's quite common practice in a lot of centres now to do what's called a TAVI CT, even if you're not considering a TAVI, any kind of aortic intervention, which is a CT of the not only the whole aorta down into the femorals, and that's where not just aortic calcium but other distribution of calcium can be very important, and calcium on the valve as well. The patterns, for degenerative disease versus rheumatic disease, you'll often see different distributions. So absolutely, it can be one of the markers. In terms of scoring, it can help you establish severity, but I think with aortic disease, a lot of the time it's easier to establish who's got severe aortic stenosis, and then if you've got a combination of severity and symptoms, done easily, you can decide they need intervention. I think a big movement in recent years has been the severe aortic stenosis who are asymptomatic. because that's actually quite a big population. And you can have quite severe AS on echo, but the patient says, I'm totally fine. And then it's a little harder to decide when to do something. Actually, this comes back to the exercise echo again. If you put these patients on a treadmill or an exercise bike, about 30% are actually not asymptomatic at all. So they just have reduced the activity that they're doing, so that's why they feel asymptomatic. And you look for hemodynamic changes or anything, but then MRI, may come to the equation there. You look for fibrosis on MRI. So to return to what you were saying earlier, whether MRI is superior. Generally, for valves, we don't use it much because the temporal resolution on echo is still superior. But for tissue characterization is where MRI comes into its own. And if you can pick up fibrosis developing in the left ventricle, that is an indication that you might want to actually get on and do something. So I've kind of completely not answered. Well, just gone on to an entirely separate question.
I forgot what the question was. I mean, it's fascinating stuff, really interesting.
No, but yeah, calcium is the enemy for sure.
TAVI versus, so TAVI stands for transcatheter aortic valve implantation and minimally invasive procedure versus surgical aortic valve replacement. Is TAVI just for the high risk patients that the surgeons don't want to do, or is there a room, or can you also do TAVI in patients that are low to medium risk?
Right. Well, I think this is probably why we're both smirking, because there's probably a bit of friendly disagreement within the heart team at the moment. Absolutely, the original indications for TAVI were surgical turnaround, so people who were deemed not suitable for surgery. But I'll say my bit first.
You're holding the microphone.
As further trial data comes out, there have been several big ones in the US and in Europe. It's fair to say that the indications have widened to intermediate risk, and in some some data for even the low risk categories as well. But to be fair and try and look at it from a neutral point of view, it's clearly a case by case basis. There are pros and cons to both techniques, and it's not as simple. If you ask the patient, and this was interesting data that came out of some of the European studies, that in France and Germany, about 13 to 17% of patients were determining what treatment they got. The patient's wishes were what determined it, which I think is, we wouldn't agree with that. I think it's not, because if you ask patients, they'll just say, yeah, of course I want to have the minimally invasive thing, I don't want to have my chest cut open. But we know that that's not the right approach. There's no getting away from the fact we have far more long-term data with surgical valves, and they're very good, they're very effective. So it's a very slow process to try and change what we're doing. But I think in years to come we'll see fewer and fewer patients.
But durability is a thing, or no? How long does a TAVI valve last for?
I mean, we've got more than 10-year data now, and I'll give you the other side of the equation.
No, I think you've been really fair, Rowan, actually. And the treatment paradigms in the UK versus, for example, North America are very different. I've got colleagues who are cardiac surgeons in North America. They haven't put a biological aortic valve in ages. If they see a patient for an aortic valve replacement, they're probably in their 30s or 40s and they're getting a mechanical valve. So biological valves above the age of 50 are now replaced by TAVI valves. Cynically, I'd say that's driven by industry, not by evidence. And so I think that's really an extreme swing of the pendulum and it's probably following the same trajectory as coronary intervention did at the advent of PCI. And it was a panacea, it's going to end cardiac surgery. And as time's progressed and as the evidence become a little bit more honest, we now know there's a place for cardiac surgery, there's a place for stenting of coronary arteries. And I think we're seeing that same evolutionary process with aortic valve disease.
Obviously a very different population to the canine patients that we see. have you got any experience, or do you know of cases, Anne, that have been operated on for aortic disorders, let's say? Because I know the spectrum of patients is very different.
Yeah, I think we had one really young Roddy that, that we did a myectomy and it didn't go well. So I think the surgeons prefer not to do them now, and I think unfortunately for us, we have quite limited surgical opportunities. So at the previous, where we were operating, we would have 2 to 3 dates per month. And unfortunately, we would choose cases that we knew would be successful. So although there are lots of dogs with subaortic stenosis and some owners that would be willing to go to that extreme, because we haven't seen great outcome, we don't really recommend it. Yeah, we don't even bring it up. Yeah.
Sure. And I think one of the things, speaking to human cardiologists in the past, have talked about with our phenotype we see in dogs, is alcohol ablation of the tissue there in the septum. Is that something that's ever performed in humans, you know, with this subaortic membrane, subaortic ridge? And do the veterinary cardiologists on the panel have any thoughts on that? Is that possible in dogs with their size?
Surgical septotomy or the ablation of the septum through the alcoholization?
I was talking about alcoholization.
Yeah, that's in human, the indication. I'm not an expert, I spend my time in congenital, but in human is an indication for hypertrophic cardiomyopathy, obstructive hypertrophic cardiomyopathy, and it's done in adult. So because you need to bring a catheter in the anterior descending, and then you have to go through one diagonal road, one of the diagonal artery, and you know, to do that in a dog, it's I don't know which kind of small catheter they need. So it's something that is done by few interventional cardiologists. They got an expertise on getting that you have the material, the size. That's one of the crucial point of interventional cardiology in dogs. We are doing many things new, and something we are inventing in dogs. And so we don't find the material, because the material is mostly done. So it's only done for human, means for children or for adult. And so, we after the fashion of the French Bulldog, we learned to put stent everywhere. We are stenting this, because they have a pulmonic stenosis that is just infundibular, they have a very narrow annulus, and then we start to stent. Sometimes we find a case of long infundibular stenosis even in large dogs. So just two days ago, I checked it after 1 year, hunting dog, very tall, big dog, that it was having an infundibular stenosis, very narrow. And you know, this was very long, the stenosis, the stenotic tract. So I remember I put one stent of 60 millimeter, so that required a long sheet, quite big. For this big dog was trouble, but the stent was too short, and then the stenosis remained. So I put a second stent, and then the two stents started to show me a dangerous stent. They were moving. So immediately I took a self-expandable stent that we use for the portosystemic shunt, something almost not exist in human, but we treat portosystemic shunt with stent and coil. That one, quite long, and they put through the right ventricular flow tract to the pulmonary artery. Fortunately, it was a big dog, and then fixed it there, and then the dog now is hunting. Even against my suggestion, if the owner brings the dog hunting, and you know, he lives with 100 of peak gradient, because he had one before. So this hypertrophy is moderately dilated, so you can have quite a cardiac output and they live. But you know, the point is, we didn't have the right stent for this. So there are many things that we will never have, probably, because we are not interested as a market, because our number of the animal we treat are so small compared to human, that many factories will never take care about that.
Talking about still aortic stenosis, left ventricular pressure overloads. We don't have coronary artery disease in dogs, so it's very, very rare. And I'd love to have your opinion in the following. We see in HCM, in cats with HCM, we see small vessel disease.
Drink.
Yeah, we have a guy that whenever I mention HCM, someone needs to drink. So we see small vessel disease. We see small vessel disease in HCM as is seen in humans. And sometimes in case of severe subaortic stenosis, we wonder also there is some histological data showing that these patients with severe left ventricular pressure overload have small vessel disease and coronary artery changes. What I would like to ask you is, in patients with severe aortic valve stenosis, before they undergo replacement TAVIs, do you check for underlying coronary artery disease? And then, is there any situation where you think maybe this is not a standard trauma, this might be just small vessel disease associated with the pressure overload, changes associated with the pressure overload? Or
Yeah, everybody going forward for cardiac surgery, typically, unless they're quite young, will have a coronary angiogram. The rationale being that if you're going to do a stenotomy, then obviously it would be a bit foolish if you missed significant coronary disease. For TAVI, we actually have now moved away from intervening on the coronaries before TAVI, unless it's very severe, sort of proximal LAD or left main. So we'll just leave it alone. So you don't actually need to do an angio if they're going for TAVI. And in very hypertrophied ventricles, what we tend to see, I mean, yes, you can get similar kind of changes, but a lot of the time you'll get a sort of myocardial supply-demand mismatch. You get a very hypertrophied ventricle, and the angina is actually more to do with lack of supply and also a very oxygen-hungry myocardium with an absence of obstructive epicardial coronary disease.
can I ask, how do you diagnose that? Because it excludes obstructive coronary artery disease.
So we've got actually now quite a lot of invasive coronary physiology, and particularly in the CTC in Essex, we do quite a lot of this. So you can put different kind of catheters into the coronaries and measure different kinds of flow across the capillary bed and across lesions and things like this. So that there are multiple. Some of this is a research tools at the moment, but we can get a lot of material, a lot of information about reserve coronary flow from these as well. So that can diagnose microvascular disease, things like that.
Okay, fantastic. So we have 5 minutes left. Any burning question? Kieran?
I've got a burning question about chest pain in animals, because Rohin mentioned angina, and obviously this is a big, massively important topic, but I'd be interested to know, Anne and Claudio, do you think you see animals with chest pain?
I think I have to say that as well, because Virginia's here, right? I definitely think cats get chest pain. I had a patient whose owner sent us a video, and it's really hard to even watch. And yeah, I think it's hard to diagnose because you can't ask, and there's not an easy way to know if there is chest pain, but there definitely is chest pain.
Take it from Anne, there is chest pain. It makes sense, doesn't it? I'm trying not to answer my own question, but I think humans get chest pain, and we see the same condition in animals, and everyone says, "Oh yeah, they look all right." Are they all right? I don't know. I think they are.
Cats are really smart, so if they experience chest pain, maybe being too active, they'll probably stop doing that.
Too active for a cat is like 2 hours a day, right?
Yeah, but I'm definitely seeing, I'm sure many people who treat cats with Sam would see that many times owners say, actually, I didn't think there was an issue, but now the cat's really active and, jumping around a lot more and interacting a lot more. So, I think that's just me kind of, retrospectively thinking about that. But yeah, a lot of owners say that.
And do we see chest pain associated with hypertrophy, ischemia in congenital disease? Do kids get chest pain with severe pulmonary stenosis or with aortic stenosis?
It's unusual in kids, I have to say, because the physiology of a young person means that they compensate. The kind of person who will get chest pain is there are particular phenotypes in adults who the hypertrophy in the left ventricle is very abnormal, and those are worrying, not just because what's going to happen to them post-surgery, are they going to actually reverse remodel appropriately? Probably not. But it's also a real concern during surgery because of being able to keep the heart happy and perfusing the coronary artery, the cardioplegia. Coronary arteries are epicardial vessels which then dive into the myocardium, particularly in a thick endocardium. It's very likely that you'll end up with subendocardial ischemia because the cardioplegia is not reaching the right point. So it's rare in kids, but I would suggest in adults it's extremely common. Can I have one question?
Absolutely.
I'm an aortic surgeon. Do cats and dogs get aortic disease? Aorta disease.
Aorta, like aortopathies.
Yeah.
Over to the panel.
In some breed, you may observe huge dilatation of the aorta in concurrence of subaortic stenosis, or, more interesting, in aortic bicuspidia, the aortic bicuspidia severe, so that one you observe generally with the dilation of the aorta. So the question is, we don't know if that, of course, we are still talking about few cases, very few to do a study, if that is a true aortopathy, like you have a genetic aortopathy in children with the aortic bicuspidia, or that is just a hydraulic effect of the regurgitation that make the turbulence and delay the aorta. This I asked myself the question because I see several cases, but I have no answer about that. So I see, but with the same subaortic stenosis, for example, if I see a boxer with the same subaortic stenosis, same degree of narrowing of the annulus, the same gradient, maybe I see in a boxer, they still have an aortic hypoplasia because they have a small vessel. These hypoplastic boxers, at least our boxer, they have the aorta is hypoplastic, the pulmonary artery is hypoplastic. It looks like Williams syndrome, something like that, some boxer. And you have in Rottweiler or in German Shepherd, this is my experience, with the same gradient, with the same subaortic lesion, they have a huge aorta. Even in Newfoundland, they have very dilated aorta. Is that a mechanical effect, hydraulic effect, or is really an aortopathy? That's very intriguing, your question, because I see there are people who have been studying this, especially in young population with aortic bicuspidia, but I don't know. I've seen some cases, but I have no answer.
What we see in elderly cats, old cats, is their aorta becomes quite dilated, and without the presence of systemic hypertension in some of these cases. Does that, to the point, well, my first question, do you see that in elderly people? As people get older, do you see their aorta to become more dilated?
There has to be some other factor. Hypertension, as Claudio said, a stenotic jet, which is causing an eccentric dilatation of the aorta or something like that. But it isn't. Our aortas don't grow with us. As we get older.
And that's funny because we see that in cats.
Yeah, it's very interesting. We just write it off and go, yeah, all cats do that.
Yeah.
And can I add aortopathies? There's a bovine Marfan syndrome. So we do see aortopathies in cows. In horses, stallions, it's not uncommon for them to rupture their aortic root. So they can have ruptured sinus of valsalva aneurysms, often presents during, what's the word? Covering? Mating? Well, horsey people have a word for it. So it's somewhat inconvenient timing, but that does happen. And the third example that I can think of is in non-companion species, non-dogs. This is dog heart surgery, isn't it? I'll show up in a minute. but is actually bears that are bio-farmed in the Far East. I'm good at pub quiz. No, I'm not. Ask Chris Linney. So Chris and Hannah have done some work on this and presented it. And these moon bears are quite commonly farmed for bile for traditional medication in Vietnam, China, Laos, other areas of the Far East. And they have bile, like bamboo catheters inserted into their gallbladder. By these biofarmers, it's brutal. Often the biofarmers remarkably well equipped with an ultrasound machine to find the gallbladder and then catheterize it. And these bears are kept in cages, and they have long-term chronic ascending infections, obviously, because they're not in hygienic conditions. It's not, they're living in a farm. And they do seem to get aortopathies, which may be related to chronic inflammation. Some have got very severe systemic hypertension. So I think we see them as a secondary problem, and we see them in very select groups of patients. They're not commonplace.
Do we know in humans why people with bicuspid aortic valves also have aortopathy? What's the mechanism?
There's a subset of those patients who've got a collagenopathy, so
okay.
They have dilatations, not just of their ascending aorta, anywhere else. They're associated with coarctations of the aorta as well, and short coronary artery origins. The left mainstem can be short in these patients. So there's a combination of findings which we occasionally get with people with bicuspid.
And then those guys will not be candidate for TAV, you candidate for aortic valve replacement. Yeah.
That's an interesting point again by translation point of view. Aortic coarctation it's never been reported in animals. Maybe there are some anecdotal reports, but so nobody observed the aortic coarctation in animals. So we see aortic bicuspidia, we see some cases of malformation that looks like the Sean syndrome, so with parachute mitral valve, with hypoplasia of the left ventricle, or what else, observed in cats, but you don't see aortic coarctation. So I think what we lack in veterinary medicine, by the clinical point of view, by intervention point of view, by surgery, we are doing not many centers, we are not many data, but we are very advanced. What we don't have is true genetical study, means true genetical study, not Mendelian, but true genetic, of course money, and more pathologists focused on this, that does histopathology. We have to collect many animals affected and bring to the pathologist, discuss with the pathologist affected, because otherwise we're chatting about possible collagenopathy in animals, but if we don't investigate, we never know.
Before we disappear too far down the aortopathy rabbit hole, I think we have to call time. So I'd like to thank, or we would like to thank, first of all, everyone who's attended this evening. Thank you so much for coming. It's incredibly special to us that you're here. Secondly, we would like to thank our sponsors, SIVA, who have very kindly made this evening possible. And finally, I'd like to thank our fantastic panel. So thank you very much, everybody.